Hi there, this is an introduction to assessment instrumentation, and in this section I'd like to focus on finger rests, or what we generally call our fulcrums. Have you ever noticed fulcrums? Have you ever seen someone do nails? And have you ever noticed this little pinky finger is usually a stability finger that supports when someone's usually doing small motor movements? This is a fulcrum, and we use it a lot. Some of the times I can remember having a fulcrum is with this game when I was little, when you take the water guns and you shoot it into the clown's mouth. I always did good with this, but I really think it was my technique. I always had a fulcrum, and I was more like this little guy down here. I had a very short distance from my fulcrum to my water gun, and that allowed precision and control to keep my hand steady. As we can see, this girl has a fulcrum. Her fulcrum is down here, her elbows, and the gun is here. And this is a long distance away from her water gun. So this little guy is going to have a little more stability. So the closer you are to whatever you're working on is always the most stability. And sometimes we don't need precision. If you want to win the game, then you want to have stability. But perhaps you don't really care if you win or not, and then you can just throw your fulcrum in the wind. So now, when we're doing instrumentation of any type, we always support our hand. So we always have a beautiful grasp, thumb across from the index finger, middle finger on the side of the instrument, fingers are stacked. We have that ring finger is our finger rest or fulcrum. It's a support beam, and it allows us to use our hand, and it allows us to pivot off this finger rest so that we use larger muscles of our arm as opposed to the tiny little muscle movements of the fingers. So with a great fulcrum, it'll give you stability, control. It's going to prevent injury from you slipping and hurting your patient. And more pressure on your fulcrum usually means more control and more comfort for your patient. It might seem strange to put a little pressure on that fulcrum at first, but your patient will prefer it. So here, a close-up, we can see an intraoral fulcrum. The patient has this finger rest or fulcrum on the occlusal or sisal edge of the teeth, and they're a few teeth away. Really, how far away you are with your intraoral finger rest or your extraoral rest really is going to depend on where you are in the mouth, which teeth you're working on, and the size of your hand. So we become all one unit with this fulcrum and grasp. We're placing our fingers on a solid surface. We have stability. The further away we are, just like the kids with their water guns, the further away, the less stability. Generally, when you're doing an intraoral fulcrum, a more traditional is a same arch, and that's a great place to get started when you're first learning, because when you fulcrum on a different arch that you're working on, it's easy to split that grasp and create too much space. Your fulcrum will really depend on what you're doing. When you're holding the mirror down, you're just gently holding a spot so that you don't move. When you're probing, again, it's stability, nice and light. When you're scaling, actually removing hard deposit like calculus off the teeth, you will modulate your pressure, and however much lateral pressure you use, you counter it with that amount of pressure on the tooth surface. So extraoral fulcrums, they can be resting on the chin. You still have a beautiful grasp though. We always use, well, no, I shouldn't say always. Maybe about 50% of the time you'll end up using an extraoral fulcrum for your mirror. Many times you can do a nice intraoral fulcrum, so do that if you can with your mirror. And it really, extraoral fulcrum is nice because it allows access in difficult areas. Typically for most clinicians, for righties, that upper right is the most challenging, and for lefties, it's the upper left. With extraoral fulcrums, you'll find that it increases your flexibility. You're able to move around, but it does decrease your stability and precision. So sometimes when you need a lot of extra lateral pressure and using very strong wrist rocking motions and you need lateral pressure, we tend to want to be closer to the area. So that is never the case with mirror explorers and probes. So with those types of instruments, they can lend themselves very easily to doing extraoral fulcrums. I also love extraoral fulcrums because it helps achieve parallelism. You can get the instruments at the right angulation very easily. It also creates an alternative. Whenever you can do something a little bit different and create some variation in dental hygiene, it's always good. So it's good ergonomic consideration to change your pattern of how you do things and have alternative methods. That is always great to create variety. Extraoral fulcrums are always great for ergonomics because you end up really using the larger muscles of your forearm, and you're always in a neutral position if you do this correctly. So if you're not, consider something might be in the wrong spot. And basically it decreases repetition. So if you're always doing intraoral, doing an extraoral will increase variety in how you do things, which is great. So here are some examples of intraoral fulcrums or finger rests. You can see, depending on the size of the patient's hand, they're a few teeth away. So the closer you are, the more stability, but you don't want to be fulcruming on the same tooth you're working on. You can see the probe here is on the second molar and the fulcrum is on the occlusal edges of the maxillary premolars. So this is a palm down approach, and here you can see a palm up approach with the fulcrum behind the instrument. So these are two options, and sometimes one works over another. You certainly run out of teeth when you, to fulcrum on when you go to the last tooth in the mouth. You can't fulcrum on that. So I find having two different intraoral rests and an extraoral for this very challenging area can be very helpful. Here on the premolars, you can see the clinician is on a maxillary incisor tooth, about 4 teeth away over here. So whatever allows you the flexibility to access the tooth. And here you can notice how the mirror is engaged in coming across the patient, and the mirror will be reflecting light, and you will probably be looking direct vision. Perhaps for the mesials and the distals of the teeth, you'll be looking in your mirror using indirect vision, and you'll be fulcruming on the occlusals of the teeth. So here on the buccal aspect, again, about 2 teeth in front of the instrument. And these fulcrums, you can see you'll be moving as you move tooth to tooth. Your fulcrum will move as a unit with your grasp and all together. Here are some more intraoral fulcrums for the mandible. And again, being mindful, you're going to have an intraoral or an extraoral fulcrum as well for that mirror hand. So now, talking about extraoral fulcrums. When you're doing extraoral fulcrums, there's a couple of rules that will help you be successful with them. You always want to stay on a bony surface. For example, you want to be on the maxilla, the upper jaw, the mandible, the lower jaw, as opposed to soft tissue or the cheeks. You tend to have to choke back your grasp on the handle and moving away from the working end. Unlike with an intraoral, you have that middle finger will end up on between the shank and the handle. When you are doing an extraoral fulcrum, your fingers really shouldn't pass the arch you're fulcruming on, shouldn't pass the line of occlusals, and I'll show you what that means. Be prepared to use a different position for an extraoral fulcrum that you would for an intraoral. Your wrist should always be neutral, so if it's not, move your chair. Ideally, these extraoral fulcrums are intended for posterior teeth. So if I say it's for the upper right, that also means it's for the buccal and for the lingual teeth of the posteriors. So for a right-handed clinician, you would reach up to the upper right, but the backs of your fingers, the backs of your stacked fulcrum will be against the lower jaw, the lower right of the patient, and you will be reaching up. For an upper right, you'll have the backs of your fingers, I just said this, will be reaching up. This is just showing you another version. And be mindful that in order to do the lingual, all you would have to do is have your patient turn to you and change your mirror placement so you could do indirect vision, and you would have the same fulcrum spot. Upper left, this is what I thought I was on. So the upper left is going to be the insides of your fingers will rest on the lower left portion of your patient's jaw and reach up to the upper left. And again, just showing you what that looks like. Whoops, sorry. So the lower right, you're going to reach down from the patient's zygoma, and your palm will be facing down to the mandibular lower right. And on this, you'll be in a back position like a 12 o'clock. For the lower left, the fulcrum on the pads of the fingers on the incisal edge of the maxillary teeth on the patient's left side and reach down. On this one, you can see that for the lower left, the fingers are on the maxillary teeth reaching down. So now a left-handed clinician will be doing things exact opposite of the righty clinician. So our upper right is your upper left is a righty's opposite side. So we just kind of flip it. So for left-handed, when you're doing the upper right, you're going to be palm down on the patient's right side, reaching up. And then the upper left backs of the fingers are against the mandible, and you are in a palm up position for left-handed. And excuse me, for the lower right posterior, your pads of your fingers will be on the incisal edge of the maxillary teeth, reaching down to your patient's lower right. On the lower left for a left-handed clinician, the insides of your fingers are against the zygoma and you will be reaching down. There are also separate videos so you can spend more time as you like, and that way you can focus on your dominant hand. So the lefties can focus looking at the lefties and spend more time, and the righties can just look at righties. But that gives you an overview of the fulcrums. So now, again, when we're getting started, we're always going to follow this sequence. We're going to assume the right clock position, treatment area, my patient, get the chair right, my equipment, my dominant hand, my non-dominant hand, and my dominant hand, and my fulcrum. And you do all of this sequence in line. So you just keep saying it every time when you're doing your prescribed practice and you're pulling all these things together. And soon, with lots of practice, you won't even have to think about these things anymore. So in summary, the basis for all successful instrumentation really begins with proper positioning, grasp, and a fulcrum in optimal light. There are options for fulcrums, and it's important to know advantages and disadvantages so that you may select the right one during the right patient situation and right treatment needs. So you will find doing these fulcrums, some are going to be easier to learn than others, and that's fine, and you'll develop preferences. Some you'll prefer, some you really won't like, and that's okay. But you want to learn them all, and it's a good goal, perhaps by the end of the year, that you feel comfortable with all of them. You don't have to know every single one of them, all of them today, but you want to start building your repertoire so that each area you eventually end up with several approaches that you could do, because every patient is different and you might not be able to do your ideal fulcrum for all patients. And plus, it's great to create a variety. It's good for your ergonomics. It's good for you to be able to mix it up.